Morning, everybody. Welcome to this Thames Valley Chamber of Commerce Women's Health Strategy on what is an absolutely gorgeous morning in the United Kingdom. And it's a pleasure to welcome our guests. And without further ado, I'm going to hand over to our chair, Sue Staunton, to take the webinar away. Sue, over to you, and thank you, everybody, in advance.
Many thanks, Gareth, and welcome, everybody. My name is Sue Staunton, and I'm chair of the Thames Valley Health and Life Science Working Group and also a partner in Accountants and Business Advisors, James Cowper Kreston. I'm absolutely delighted to be joined by Catherine Edwards of Health Innovation Network, Emily Mitchell of Bayer, and Jonathan Evans of ABHI for their insights into the strategy document that was released recently by government. I think it's just, when we were just talking about it before everybody joined, it's astonishing. I've not yet, or not previously, read a government document that has had such strong language denoting a degree of passion around the desire to do something to improve women's health. Language in the foreword from the former Health Secretary, Wes Streeting, included, the NHS is structurally failing women, that there's medical misogyny, and there is persistent dismissal of women, and that's really very inflammatory language. And it would be very interesting to get the take of the panel in terms of what their views are and whether they think that the rhetoric of the foreword is actually followed up by strong deliverables and strong policy. So, as a brief introduction, Catherine, why is closing the gap for women's health so important? Not just a matter of fairness, but also to do with societal and economic imperatives.
Thank you, Sue. So, just for a bit of grounding as well, when we're talking about women's health, sometimes I think it's a little bit unclear what we're talking about because women are 50% of the population, and there is a lot of things that have consequences for our health. But for this conversation and for the strategy, the way it can be easier to think about it is women's health is three things. It's conditions that affect women exclusively. So you're thinking about things about your reproductive system, so endometriosis, menopause, heavy menstrual bleeding, that kind of things. And then things that affect women disproportionately, so things like autoimmune disease and Alzheimer's, osteoporosis. And then thirdly, things that affect women differently. So that's including things like cardiovascular disease, metabolic conditions, and certain mental health conditions as well, as examples. So I think just from even that setting, we can understand that women's health isn't a narrow niche area. And I think hopefully the women's health strategy is starting to move it towards that way. It really is a broad set of challenges that are affecting the half of the population in a lot of different ways. So the so-called women's health gap has come about for a number of different reasons, historically through a focus more on the male body as default, and that's been through the way systems are set up, the way training has been set up, the way research has been set up, the view that potentially just it should be looking at reproductive systems are the only main difference with it between the sexes, which as we've progressed is clearly not correct. And we have a significant issue with the fact that clinical research, for example, in the years gone past, for sometimes considered valid reasons as well. So women who are of childbearing age, so potentially being able to bear children, be pregnant, have been excluded from a huge number of trials so that there was no risk to a potential pregnancy. But this has biased a good lot of the research and then clinical knowledge that we have going forward. So what this has meant is that we've got a system which has got inbuilt inequalities, regardless of how well we're trying to deliver good individualized care. And so that can manifest its way in things like women will suffer more adverse drug reactions than men, partly because that dosing and side effect profile has been historically based on male profiles. cardiovascular disease, women are more likely to be sent home or misdiagnosed than men presenting with symptoms. And even things like common conditions like asthma, they've been found that the standard inhaler protocol is not quite as effective for women as it is for men. So, as well as the significant effect of problems with the system of how gynecology conditions are treated, for example, we now have currently 600,000 women on the waiting list for gynae. We can see that essentially these shortcomings in the whole system are not just bad for women's health, they're bad for the society as a whole. So economically, it's a huge impact on productivity, retention at work. 61% of unpaid carers are women, so has any effects on them, has a significant effect on their caring ability as well. And for example, your NHS workforce in itself, so the people that we are wanting to make sure that they're being able to provide the healthcare, 76% of the workforce in the NHS are female, so there's a disproportionate effect on them as well. So this isn't just a problem that is affecting women, it is affecting the whole of society, it's affecting men, it's affecting their families and who they care about as well.
Okay, well, thank you very much, Catherine. And so to the rest of the panel, has the content and ambition of Women's Strategy document met your expectations? Emily, what's your view on this?
Yeah, I mean, echoing what's been said so far, I think the strategy is a really meaningful step forward, and I think it really represents this momentum that's been built over the last few years in women's health. So it's really great to see that solidified in this national policy document. And I think importantly, it makes the point that it's both this combination of trusted information for women, but also timely access to services. And those two things together is what is making women's choices real, so that women can act on their preferences rather than be so affected by system constraints and things like that. And, Bayer, we've got a long heritage in women's health. We really welcome commitments to streamlining access to care for contraception, for example. But also, we really applaud this integrated approach to looking at women's health through setting out the disparities that women face in areas like cardiovascular disease as well.
I mean, there's quite a lot of talk within the document, I think, isn't there, about not just the disparity between men and women's health and how those are looked at, but actually also for women, where they come from in terms of, the social differences as well, that seem to be disproportionately affecting women compared with men.
Absolutely.
And is this the first time that we've seen this really being fully articulated, do you think?
So from my perspective, it's something that we definitely discuss a lot ourselves and with stakeholders. What is really encouraging is to see this commitment to measuring success of the strategy by looking at how that gap between contraception access between the most and least deprived areas can be closed. And so it's really great to kind of see that in print and see that commitment.
Thank you. Jonathan, what's your take on whether does the strategy meet your expectations?
Yeah, well, I think it's certainly significant, both in terms of the tone and the ambition, as you outlined at the start there, Sue. I mean, cynical hat, clearly it's overdue, and the fact that we now need a strategy to tell us that women have an important role to play in the economy and their health is important. Cynical hat away. It's a positive thing, and absolutely we're supportive of that. I think what's particularly encouraging is if you look a lot of the historic failings for women, it's actually a lot about women not being listened to, and that's at the heart of so much of this. So I think actually it's maybe viewed as a little bit of a softer element of the strategy, but I think it's kind of writ large across everything that needs to change. So that's important. That's been recognised, I think. And as Catherine very, very eloquently said, it's the male physiology has always been the default. So we're almost having to rewire the system from everything from medical education through to clinical data sets and how you launch innovation, and obviously the funding as well. I mean, only 4% of funding from kind of like venture capital and things like that goes into women's specific health. So there's so many different elements across the pathway that we need to really be looking at this. And it's, it's, as one of my colleagues said recently, if you were making products that failed 51% of the market, that is not a viable business. So, we need to really think about who are we serving here. So I think all of that is recognized and captured in the strategy, which is a really positive thing, and it gives us the impetus to drive this forward. With my ABHI hat on, so we're a trade association representing the health tech sector. Many of our companies are very active in the Thames Valley region as well. We've been looking at this for quite some time. We did a Women's Health Summit earlier this year, and off the back of some of our reports as well. And our strategy is very much aligned to those three areas that Catherine identified at the start as well. And we're trying to bring this to a global audience as well, bringing along our global trade association colleagues on this journey. So it gives their respective memberships a platform to engage. It allows us to share best practice to avoid any duplication, but to bring our respective health systems on this journey as well, because I think that's an important element of this as well. So there's a few different areas where we're playing, but fundamentally it's driving in the right direction. So I think that was some of the elements I wanted to highlight. But I think having that women's voice at the heart of this is going to be what really kind of brings it to life.
And I think that was something that was very much drawn out within the document from what I could see, was that they had, and sounds a bit patronising to say, but they had actually gone and spoken to women, and that they had taken input from a large number of women, as opposed to telling that this is how it's going to be. There was a degree of listening. Catherine, what's your perspective on whether this meets your expectations as to what's needed?
So I think pragmatically it's really encouraging at this stage of where we are at. I think the UK in doing this is actually quite at the forefront. Jonathan was mentioning ABHI going out. So I was recently in Europe, and this was coming up as a discussion. And realistically, it looks like Australia has done something similar, and Europe are trying to do something similar. So we are at the forefront. But having said that, there are so many intrinsic problems that this document didn't have a chance of being able to solve any of them. It's a start. Realistically, the strategy that came first should have been the start, but I don't think it actually ever managed to do that. It never managed to catch on. So I think it does stay quite based in the reproductive side of things, but I think you can't bite every bit of the cherry all at once. I worry a bit about how much the strategy still just sits in ambitions, rather than being really discussing the how. And I don't think maybe we know the how yet. I think that is a lot for the systems to work out how to deliver. And that's my concern, is that in a time of significant pressure and upheaval within particularly healthcare providers and ICBs, etc., this might not raise to the point where it should do, because it's not currently got many very clear, you must do this and you will do it like this. So it's about that continuing conversation, what continues to happen as a result of this strategy.
I mean, yes, because I think one of the big criticisms of the 22 strategy was that it was a nice document, but it didn't actually have a plan attached to it. And if we think about key gaps within the 26 strategy, do you feel that is one of the gaps still? I mean, I think they've gone a bit further than 20. They've gone a bit further.
I think they've gone a bit further, but yes, I do. And the resource behind this is very, very unclear. There's a nominal amount of money of 1.5 million for a femtech challenge, which is really nothing in the scheme of things. And there's not a great deal to address the workforce issues and the sort of skill issues that are underlying quite a lot of the problems at the moment.
Emily, what's your view in terms of key gaps in the strategy and what we should do
Yeah.
to deal with that?
I mean, I don't see a huge gap in ambition. I think the ambition is strong, but really it is about how this will consistently land in practice to address the variation in access to services and also variation in women's experiences as well. I mean, for example, we're really supportive of this 2-year commitment to streamline access to contraception and simplify the front door to services. But I think that delivering that easier front door is going to be really difficult if the system conditions aren't aligned to deliver it. So one of the things that there's been really strong consensus on, even since the last strategy, it's built even further, is this fragmentation of funding and commissioning structures that sit behind delivery of things like contraceptive, menstrual health services and things like that. So I think the strategy does a good job of recognising that as an issue, and it sets out the SRH commissioning framework as a route to addressing it. My worry is that could potentially kick the can down the road unless the framework really kind of delivers. And I think that's the opportunity as well, is to really, for that framework to reflect the strong consensus that exists on some of these core systemic barriers that, if addressed, could help, as Catherine alluded to, could help create the right conditions in which system to decide how to deliver things.
Yeah, and Jonathan, what's your view in terms of, we've heard about some of the concern around gaps, but do you see any other gaps within the strategy document itself?
Yeah, I mean, it's, as the guys have said, it's very strong in its recognition of the challenges. There are 117 actions in that document. Now, I don't know about you guys, but if you were setting your objectives with your line managers, I wouldn't want 117 priorities. So there is that, and there's no money. Admittedly, a lot of those actions are linked into existing things that are ongoing, things like modern service frameworks, etc. But it's hugely ambitious. But you do need that consistent leadership and workforce as well. I think it was Catherine that mentioned it is a major issue. So if you think about women's health hubs or neighbourhood health more broadly, those community pathways and different services, they need trained staff, they need sustainable funding, they need integrated working between primary care and community settings, all these different things that do require resource. So that's a big one. But I think that in a space where we all sit as well, the challenge for the technologies out there, it's not necessarily the invention. There's a lot of great technologies out there that can really enhance outcomes for women and society at large. The challenge is often the adoption of those technologies. We still see massive variation across the health service in terms of how quickly innovation is evaluated, commissioned, procured, and then scaled up. To the point where you often see UK innovation being used else in other countries, but not in the UK, which is a crying shame. But so I think, clearly the strategy's focus is welcome, but I do think it needs to be linked in with broader NHS adoption, because for companies doing business in our country, you have one customer, don't you? It's the NHS. And okay, there's an independent sector, but by and large, it's the NHS. If we can bring the operational service along with us and procurement and adoption, that will make a really tangible difference. You think about waiting lists, you think about outcomes and patient outcomes. That's the piece for me that I'd like to see joined up. It's an amazing opportunity, though.
Yeah, I mean, one of the things that occurs to me is that it's not just about what is being delivered; it's also about, I think, sort of women understanding that there is a shift, there is a strategy. Because I'm not sure that I've seen this particularly well publicised outside the industry, and those people who already know and understand there are issues, and of course the NHS. But I sort of feel we need women to actually be more on the front foot and not to feel this medical misogyny or the fact that they are just treated in the same way as men, and that their bodies are dealt with in the same way as men's bodies. Catherine, you talked about cardiovascular issues, you talked about drug protocols and that sort of thing. And I think that's something that we also need to sort of have a pincer movement around. And I'm not sure there's enough in the strategy, personally, talking about how we educate women to ask for more. But
yeah, if I may just quickly come back as well, Sue, the interesting, I mean, the majority of household healthcare decisions are made by women, and women will typically utilize health services far more than men because, you know, thinking about menstrual health, thinking about childbirth and things like that. Those are clearly interventions that I wouldn't need, people who look like me. So women engage with the system more and understand the system more, but it's not made for them. So there's a fundamental dichotomy there. But I think to your point, Sue, there is something about awareness here, isn't there? And it's from everything, as I mentioned, from the medical schools challenging assumptions to the training to us in industry saying, you know, is this data sex disaggregated? All these different interventions that we can do collectively that will see positive change.
I mean, that leads on to, you know, having talked about the importance of the strategy, do we believe that it's capable of successful implementation? And we've talked about budgetary constraints and some of the issues, but what do you all think, Catherine? What's your view on this?
I think large parts of it are, and I'd be very hopeful. I think, I mean, just fairly straight and simple things like the requirement and consideration of pain relief for procedures like hysteroscopy. That seems that should not be that difficult. It really shouldn't. So I'm hopeful that some of those key things that they have discussed should really be quite straightforward. And I think things like that are ones where women's voices have been really quite clear. And like Emily mentioned, I was quite encouraged by the amount of consideration they're having for women's voices and getting feedback, etc. I think when it comes to, so one of the things that when we had the meeting before, we talked about women's health hubs quite a bit because there was the Royal College of Obs and Gynae, very, very keen on that model, and it's been successful in many different places. It was a little bit disappointing that you don't see that articulated quite as much as we'd have hoped in the women's health strategy. But what they're trying to do is tie it to neighbourhood health. So it's become something slightly different and a little bit more opaque within that. So you'll hear them now being called Women's Integrated Neighbourhood Systems. WINS, they've always got to have an acronym that's, you know, so WINS, everybody. So I still think those are quite vital for that kind of one-stop shop of being able to be advice and guidance for services referring into them, for being able to take activity out of secondary care that doesn't need to be in there. So I think through the threads of the strategy, that's all there. I was just a little bit disappointed that it wasn't quite clear that that might be the mechanism. So perhaps the pressure isn't quite so much on how much those women's health hubs or WINs should be in place. But for example, for the Thames Valley, for the ICB here, it is in their commissioning intentions that they will have one cover. They will have women's health hubs covering all their areas within the Thames Valley. So it is there. I think the momentum has started and it's really rolling. So that's another thing I'm hopeful with this strategy, is that behind it there is a lot of momentum from healthcare providers, from women, from industry, from a lot of different areas that will force some of this to happen. And a little bit like Jonathan said, a lot of it is actually embedded in other strategies as well. So the 10-year plan, it's embedded in there, things around cardiovascular embedded in there, MSK, etc. So it has got other mechanisms for delivery as well, rather than just being seen as the women's health agenda.
Emily, what's your view in terms of implementation?
I mean, I would say that there is proof around the country that much of the aspirations in the strategy are implementable. There are lots of good practice areas that exist. You know, Cheshire and Merseyside was mentioned as one of the success areas in how they've supported addressing inequities in access to contraception and things like that. But as Catherine says, there is a lot of change happening in the system. Pressure systems are under is immense. So I think it's recognizing that good things exist. The challenge, I think, lies in the ability to scale these solutions everywhere to close the equity gap, so that wherever you live, you kind of have that similar experience entering the system. And I think the strategy does really align so strongly with the government goals, particularly on prevention. And so that is my hope, that in this environment where, we've got over 100 recommendations in this strategy, there are other large national documents coming through. We've got the 10-year plan. The things that most align to delivery of the 3 shifts is what I hope that the government will kind of keep that momentum and support prioritization of those things, acknowledging that, not everything can be done. And I'd be keen to understand, in terms of implementation, a bit more around how success will be measured. We always know what is not measured isn't managed, and how systems can be supported to create the conditions to kind of meet those expectations. So I think, I've got hope. There are good areas out there, but I am intrigued to see how systems will be supported to scale that elsewhere.
Yeah, and Jonathan, your views, you coming from an industry perspective, what do you see in key issues with regards to the implementation?
Yeah, clearly I'm optimistic, and as Emily mentioned there, the 3 shifts that we have to mention in these forums that we have, they're all highly relevant to women's health, right? So strategically, you have that alignment, which is obviously a positive thing. Do come back to, we are trying to modernize the health system, whose scientific foundations are not designed around women's physiology and lived experience. So I think partnership is going to be really important, and that is kind of captured in the strategy as well. So it does explicitly recognise the role of collaboration between NHS, industry, academia, patient groups, and sort of broader healthcare stakeholders. And in the UK, we have all the assets, right? We've got incredible research, academia, strong industrial heritage. So we have all the kind of the assets that can see those improvements. And I think, as Catherine said, there is a real opportunity from a regional perspective, where you've got strong and consistent local leadership to drive some initiatives that can then be built out and shared across the country. So I think, clearly national strategies are important and they can drive that direction, ambition, but delivery often happens at a local level. And I think, we are seeing through that sort of direction of travel some real strong system leadership come through, which gives me real hope. And actually, that's you can wait all day from the centre, can't you, for money and direction, but actually there is something about just getting on and doing it. And I think that's where we'll see some really strong outcomes in patches like Thames Valley and. We mentioned Merseyside, didn't we? Leeds and Manchester and places like that are really kind of on it in terms of driving that local outcome. So I'm positive, I think.
Yeah, good. Okay. And I think, just sort of direct question to you, Jonathan, you talk about the importance of integration of academia, research and so on, but and Catherine earlier spoke about clinical research, sort of we've got pools of people that aren't actually being part of a trial for particular reasons. Do you see that central government and the MHRA perhaps ought to be specifying far more of the inclusion of women and, particular diasporas of women in terms of their research that is being funded?
Yeah, well, this is very much on their radar now, and I think NIHR research actually has to be disaggregated now, which is a really positive step. And I think when you kind of apply this to this patch that we're thinking about, Thames Valley, you've got absolutely world-class universities and healthcare institutions and major life science expertise that can drive some of this. So there is a little bit of mandating and the whole carrot and stick and all this sort of stuff. regulation as well, and how you maybe whether some of these sort of adoption pull through mechanisms and things that I think probably should be looking at some of these elements as well. But we are getting there, but there's clearly more to be done. But I think there is, major opportunity, and I think this region in particular is as well placed as any to drive some of these activities locally.
Yeah, yeah. So coming on to that, then you've just said, Jonathan, Thames Valley is a very important area for health and life science. What should we, as people who sit within that region very much, and specifically within the Chamber's Health and Life Science Working Group, what should we be doing to best support the implementation of the strategy? And Emily, what are your views on that?
Yeah, I think we're really well placed in the group, given that the strategy does a good job of recognising the impact of women's health in all corners of life, obviously health and participation in day-to-day life, but also work and employment and things like that. And I think that the Thames Valley, we're in a good place to emphasise the importance of that and the economic impact of getting things right for women. First of all, it's the right thing to do, but also then the other effects are beneficial for not only individuals, but also around the region as well. I think we have such a strong health and life sciences sector in Thames Valley, and the working group does a great job of facilitating links between ourselves, politicians, NHS, and the rest of the sector. So I think we should really be leveraging how well the Chamber has brought this group together. Jonathan spoke about integration, and I think that is the key in being able to work together to address some of these challenges. I think what we can do moving forwards is help to amplify or highlight some of the ways that is happening to the centre, so that the Thames Valley can be positioned, as an area that is doing well, and an area that the government can look to help deliver some elements of the strategy.
Thank you, Catherine. Sitting where you do in the Health Innovation Networks, you're sort of that bridge between NHS and academia and the deliverers of services. What's your view as regards that? What can we all be doing?
So I think there's probably a few things on the kind of momentum side. I think we've got a significant contribution to make. I think the economic argument for focusing on women's health, I mean, some fairly recent research indicates that for every £1 spent in this area, the UK economy will get £11 back. Arguments like that being made consistently and in the right places, I think, can open doors where perhaps things about, I'm being cynical here, women's pain or problems might not. I think this organisation in particular has can be quite effective with those kinds of arguments. I think as well for sort of the members as well and people who are working in industry is about thinking about what you're doing. Has your product, what you're working on, are you actually looking at the gender differences, and have those been studied? Have those been measured? Have you really actually considered what that means for the system, how they're accessed by women? Even just the sort of human factors of how they're used by people who might have smaller hands, for example. So thinking about medical equipment, my background is midwifery, and actually some of the equipment that we used to use isn't actually that easy to do with a smaller frame than a larger frame, let's say that. So I think there's that, and there's also we're employers across the board with women in our organisations, and so all of these inequalities about women's health and how those being dealt with, those there are things that employers can do, looking at things like menopause care and menstrual health, etc., to help the retention of productivity for their women in their workforce as well, I think. And it's really, really, as Jonathan and Emily have both been saying, about a collaborative process. The system is complex and has become like this over many, 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 many years. So it takes a lot of unpicking by absolutely everybody within the system working together to the ends of trying to make it an equitable system for everybody.
Thank you. And Jonathan, what do you think we can do in the Thames Valley specifically? You alluded to some things because you talked about the strength of the Thames Valley, but what specifically actions could we take through the Health and Life Science Working Group in the Thames Valley to improve things?
Yeah, I mean, as Catherine said, implementation of the strategy, it's not going to live with one organization or one sector. And so I think that's the value of a group like the Thames Valley Chamber is being that convening platform that brings those different voices together. And you can do things locally because you have, as I said, all of the assets that would be the envy of other parts of the country and actually internationally as well on this distinct geography. So yeah, you think about the kind of clinical research and innovation expertise that sits there. So there are certain things that can be done, and I think so Catherine is one. She sits in one of 15 health innovation networks. So if we can do something here, how can we scale that across to the other 14? Yeah. How can I at ABHI, which is a national organization, but actually our chief exec is involved locally with the HIN, Peter Allingworth, who chairs that. How can we take that to other jurisdictions, our trade associations in other countries as well? So we can bring them along on this journey, but using some of those local exemplars like the Thames Valley as a best place or best practice geography. So there are things that can be done, in particular, I said the links into the health service there that can be done locally. And to quote you or misquote you earlier, Catherine, about taking many bites of the cherry or boiling the ocean, whatever you want to say, make some small changes that demonstrate that impact, and you can hold a mirror up to government and say, hey, look what we're doing. You've released this strategy that comes with no funding, but we've taken it on ourselves to do this, demonstrate this, because it's the right thing to do. And then it becomes a little bit harder to ignore then, doesn't it? If you can demonstrate those impacts. So I would say, yeah, to go back to is to get on and do it locally. And you have all of the assets and the impetus now to do that.
I think that's because then we create this push-pull situation, don't we, where it's coming up from the bottom, coming down from the top, and it has a degree more momentum because neither party will let it stop almost. So thank you. So, conscious of time, final thoughts from each of you as to your feelings about the women's health strategy for 2026 and what your final thoughts are in relation to it. So let's start with Catherine.
So I think final thoughts were to summarise that I think this is such an important area for us to be focusing and working on. Extremely pleased that we've got some momentum in the UK on the back of the women's health strategy. Let's use it, let's leverage it, and really echoing what Jonathan was saying, that we've got such potential in this area. It's about identifying what we can do, best practice, best innovations that we can hold up and show to other areas within the UK, externally to the UK, that can really help the women's strategy move on to make an actual difference for a more equitable health service.
Thank you. Emily.
Yeah, I mean, I echo Catherine's comments in the hope that the strategy brings. I think in the short term, really want to see some of the commitments in the strategy moving along, like the commissioning framework and things like that. But I think, Sue, you were saying earlier about, you're not sure how in the general population of women, how well known is, the publication of this strategy. And I think, whilst I personally really enjoy reading the strategy, I'm a policy person, I think what is really important for women is to, in however many months, years time, to be able to feel the difference that the strategy has made, to feel like you've got the right information to make the choice that meets your preferences, but then also you then kind of receiving services and access to care in a timely manner. So I think that's probably the most the most important thing for me. And I think that if the government can prioritise these areas where there is such a strong tie to prevention, and women's health is one of the areas where we have such strong data on the return on investment as well, and the longer systemic effects. If we can bring that recognition together to drive forward some of those commitments, then that would be my hope for the next few years.
Thank you. And Jonathan, your thoughts?
Yeah, I mean, absolutely echo that. I mean, the strategy is the right thing to do. It's a no-brainer, right? And I mean, the government has well, it said it saw out early doors, and the next election, if they can get waiting lists down, that was a big thing for them. Well, here's one you could really drive a impact here. I think just to add as well, I mean, I'm quite unashamed about talking about the economic impact here. If you're Rachel Reeves and you sleepless nights about productivity, growth, savings, all these other things, well, look at what we said. What was it? Invest £1, you get £11 back. I mean, you're not going to find that anywhere else, are you? So we should be quite front and back think about that. Actually, the economic benefit of getting this right is another one of those things I'd file as a no-brainer. So I think we should, really champion that element as well.
Thank you. Catherine, Emily, Jonathan, thank you so much for your insights today, for your time. I think it's been great to be able to talk about the health strategy, and look forward to hearing more. Our next meeting for the working group in a couple of weeks' time, Catherine's coming along to that to speak, and hopefully Emily and Jonathan will be able to join us as well. And we will be pushing on with that front very much from the Chamber's perspective as to how we can help to make a difference. And we can be, very much Jonathan suggested, the convener of all the different interests within this to drive this forward. Thank you very much, and wish everybody a good weekend.
Thank you.
Thanks,
everyone.
Thanks. Enjoy the bank holiday.